All right, so I am standing between you and the next speaker. If we can pull his slides and to start the meeting, it's my honor to welcome our next speaker, Professor Miklos Sahintoth. He is at University of California, Los Angeles, UCLA, and Miklos is a world-renowned scientist in the mechanistics of pancreatitis model. We can't wait to hear your talk, Miklos.
Thank you, Masha, and good morning. So it's really humbling to be the first speaker and kicking off this wonderful meeting. And they've created a tremendous tradition here, and I'm really thanking Masha and Randy for taking leadership and taking us to the next decade. Let's kick off with a little bit of basic science, looking at the role of genetics in providing mechanistic understanding of pancreatitis. So I made this talk a little bit educational, sort of some historical overview, and showing you some examples of our work, how we used human genetics to model diseases in animals and try to get some mechanistic insight. And this is the scheme in most genetic diseases. Scientists follow. You base your research on findings in humans. You do lab tests in test tube functional studies of different genetic variants, mutations, and then you proceed to animal modeling. And once you have good working animal models, use these models to do preclinical testing. So where do we stand in terms of this scheme if you look at chronic pancreatitis? I think with past 25 years, there was tremendous progress in human genetics, and the understanding of risk factors for chronic pancreatitis is close to complete, I think. And we did a lot of functional studies of these variants. And the past 10 years was very well spent on animal modeling, and I'll show you some examples. Where we are falling short at this point is using these new models for appropriate preclinical testing. And in this regard, yesterday's session was extremely encouraging, that we saw that there's new ideas, and hopefully they will be matched with the appropriate models. So just to show you this slide and remind you that if you think of pancreatitis as a disease spectrum, as a disease continuum, then genetic risk factors mostly affect progression from acute disease to recurrent acute and then to chronic disease. In fact, progression is really driven by any kind of risk factors, environmental like alcohol, smoking, or the one I'm discussing today, genetics. So genetics of chronic pancreatitis has become very complicated and complex over the years. A number of genes have been discovered, many mutations belonging to different genes. So what we've been trying to do for quite some time is to organize these genes into what we term pathological pathways. And this is just a mechanistic framework to sort of group the different risk genes. And right now we differentiate 3 pathways plus an unclassified group. So the clinically probably the most common is the trypsin-dependent pathway, where you have genes that modify intrapancreatic activation of trypsinogen to trypsin. And the genes that belong here are, it's a little code here for every gene. So PRSS1 is cationic trypsinogen, SPINK1 is a trypsin inhibitor, and then you have the chymotrypsins C and B1, B2, which are actually protect against pancreatitis by degrading trypsinogen. So there's a subclass of different mutants which belong to so-called misfolding-dependent pathway, where the mutation changes protein folding and results in enzyme misfolding and endoplasmic reticulum stress. And the best known examples are carboxypeptidase A1 mutations, CPA1 mutations, but you see some other genes listed here. Even trypsinogen belongs here. There's a special subclass of mutations which are different from the trypsin pathway mutations. And then some rare mutations, P and LIP or carboxyester lipase, and even some a subgroup of chymotrypsin C may belong in this group. So the misfolding dependent pathway is really studied very actively, and we had some nice discussions yesterday also about it. But clinically, this is less commonly found, and mostly in the pediatric population. So the ductal pathway, again, is very common clinically, and the CFTR mutations. So these are heterozygous carriers who don't have cystic fibrosis. This is the best example. And the new finding from the past 2 years is TRPV6 calcium channel, which is a very strong risk factor for chronic pancreatitis, not too well studied. And we put Claudin 2 here, which is less well understood, mechanistically. And finally, there's some interesting rare but unclassified risk genes, protease-sensitive mutants of the pancreatic lipase, the membrane protein CUSD1, and some elastases belong here. So we study all of these genes in the laboratory and in mice. So I'm going to focus on the trypsin-dependent pathway because this is the best studied and the longest studied, and this is the dearest to my heart, and this is clinically fairly frequent. This is jumped. This just one back. Okay. So just to remind you, this was Dave's 1996 paper, which described the first risk gene, which was the cationic trypsinogen gene in hereditary pancreatitis, and the first mutation R122H. So animal modeling has been really focusing on this particular mutation for a long time. And I'm showing you here the first paper, which was published in 2006, and all the other papers on this one particular mutation. There's a surprisingly large number of papers. So most of these are actually unsuccessful attempts to model this mutation. And the more recent one from Bo and G's group from the Mayo Clinic are actually very nice phenotypes, but there's very difficult to understand mechanistically. And so by and large, modeling this clinically common mutation has been very problematic. And the reason for that actually became clear from biochemical studies. Because what I'm showing you here is the why and how the mutations of trypsinogen actually increased activation to trypsin. And as you can see in humans, there's an intricate regulation by chymotrypsin C. Chymotrypsin C promotes degradation of trypsinogen, and many of the mutations interfere with this degradation. And R122H is a particular example of this. And there's a secondary effect of chymotrypsin C whereby it stimulates activation, and some mutations actually drive this pathway. And there's some mutations are completely independent from chymotrypsin C. Now, when you want to model this in mice, then you run into problems because, for instance, the black 6 strain, which we commonly use, is naturally deficient in chymotrypsin C. So it becomes inappropriate to model, such a biochemical scheme. And even though in mice, the basic idea of chymotrypsin-dependent, regulation is there, the details are different. So we decided to model this, we need to simplify the system. And we made it this simple. So just look for mutations which stimulate activation and result in high trypsin levels and test whether you get pancreatitis or not, and eliminate this whole chymotrypsin-dependent regulation from the scheme. Keeping in mind that in humans, in most cases, there is chymotrypsin-dependent regulation. So we took advantage of the fact that the trypsinogen has a short activation peptide, which you can manipulate. But this is cleaved off, and any mutation you introduce here is not going to be present in the final trypsin product. There are mutations in patients in this segment of trypsinogen. They are less frequent clinically. So we designed 3 different mutations, and these are 3 different mouse constructs I'm showing you. And these are not necessarily found in patients. Some of them are artificial mutations designed to achieve different levels of trypsinogen activation. And as you can see on this slide, the activation site, there's unfortunately the arrow has shifted. So that was supposed to be after the red lysine, where the activation takes place. And then we manipulate the amino acids at or close to the activation site. And the idea is the following. If you look at this, this is a test tube experiment for the 3 constructs. So each mutation drives autoactivation of trypsinogen to a different degree. So the mildest mutation increases activation 5-fold, the strongest 50-fold, and there's a mutation in between about 13-fold. And in this particular time course, the wild type trypsinogen, which is denoted T7, hasn't even started, activating yet. So now we have a situation where we can test whether if you increase trypsinogen activation to different degrees, what effect does that have on the pancreas? And I'm going to give you the punchline first and then show you some examples. Also, you have to remember that in mice, you can manipulate the number of alleles because there's 2 chromosomes, and you can study homozygous mice or heterozygous mice, which increases or decreases your gene dosage, which overall gives you 6 combinations of trypsinogen expression. Again, it's skipping. So we observe 2 different phenotypes with these mice. One is mice develop spontaneous acute pancreatitis, and they rapidly progress to chronic pancreatitis. And if you see that these mice actually recapitulate to some degree the human condition, where you develop from an acute attack, you can develop, even though there's no recurrence in mice, but they do develop chronic pancreatitis. And the D23 heterozygous mice, or this complicated mutation homozygous mice belong here. If you D23 homozygous, you cannot study because those mice actually do not develop well. They deficient. But otherwise, these mice, despite their severe pancreatic pathology, they breed well and they actually quite happy. Now, if you take mutations which drive trypsinogen activation to a lesser degree, you do not get spontaneous disease, but you can induce disease which is much more severe than in regular mice, and it spontaneously progresses to a chronic-like state. And these mice also do great, and each model is actually very valuable, because in the spontaneous model, you sort of model the human situation where we spontaneously get disease, but the induced model is much more controllable. So for experimental studies, it's probably better in certain situations. Okay, examples. Spontaneous disease. So I'm showing you the D23A mice, which up to 2 to 3 weeks, the pancreas looks normal. And in mouse, you see a very tightly packed pancreas. You cannot really make out the acini. It's nice and pinkish. And within a few weeks, at age 3 to 4 weeks, they develop this massive acute pancreatitis, where you see edema everywhere. You see the usual strong inflammatory cell infiltration and pinkish areas of necrosis, in the lobules. And interestingly, the progression to chronic disease is rapid in this model. 5 to 6 weeks, you see what we termed early chronic pancreatitis. And this is not a clinical terminology. This is just a histological terminology, where you see acinar atrophy, acini disappear. You see fibrosis and these big dilated ducts. And eventually, as we see in many mouse models, you develop not fibrosis, but mostly adipose replacement, and you see the islets are intact. It's really, the pancreas looks like what we saw yesterday when you inject acetic acid into the pancreatic duct, and acini die, and you're left with islets and fat. So this is a spontaneous model which you can actually utilize for preclinical studies very easily, and the mice, as I said, they do really well. So in other mice which do not get spontaneous disease, you can induce disease. This is what you observe, and these are higher magnification histology slides. And the left side is the black 6, which is the control wild type mice, and the right side are the trypsinogen mutant mice. And if you look at the acute phase, day 1, In the mutant mice, you see, bigger edema, more inflammatory cells. There's a more severe acute response. But the interesting thing, what happens after that, normal mice immediately recover. By day 3, they histologically look almost normal. But trypsinogen mutant mice, even though there's no more stimulation, they start to progress into this chronic-like state, which is driven by acinar atrophy mostly. And if you look at 2 weeks, 1 month, even 3 months out, normal mice are completely recovered. But the mutant mice still struggle. And even at 3 months, you see adipose replacement, you see some scarring. The pancreas is not normal. Now, one way to follow this actually very nicely, which a lot of groups don't do, and then this is this is going to be my legacy that I introduced into the pancreas field, the laboratory scale, to measure the pancreas weight. This is a very simple and easy parameter to follow. And if you look at these mice I showed you and you measure the weight as a function of time, and look at the black symbols, what you see that during the acute phase, there's an increase in pancreas weight due to the edema. And then you can appreciate the rapid atrophy as they progress to chronic disease. And day 5, day 6, they bottom out. And the recovery is extremely slow in the trypsinogen mutant mice. In control mice shown in white symbols, you see a little increase for the edema in the acute phase, and then pancreas is normal. Actually, the weight increases a little bit as the mice age. Now you can see on this scheme that you can design preclinical studies around this very easily because it gives you convenient readouts. So one of the convenient readouts is like day 6 atrophy, which is a trypsin-dependent, easily measurable, readout to test efficacy. And we have been using that. But you can also use day 1, edema as another convenient readout. So going back to this scheme I already showed you, this gives us some ideas how to go about therapy in case of trypsin-dependent pancreatitis. And you have many options, but I'm listing two here. One is we can block trypsin activity by some sort of drug therapy. And this has been tried for decades and decades. The problem with prior studies is that in the preclinical setting, we didn't have trypsin-dependent models, and trypsin inhibitors were tried in non-trypsin-dependent animal models, where of course they showed no efficacy. Even in the clinical settings, many of these trypsin inhibitors were tried in disease, which is not trypsin-dependent. For instance, post-ERCP pancreatitis is a common clinical test scenario, which is not dependent on trypsinogen activation. The other possibility is, since chymotrypsin is protective, we can increase chymotrypsin activity in the pancreas through gene therapy. And this is very theoretical at this point, but maybe in the near future, we can explore this more. I'll show you one recent example, what we've done testing dabigatran using these newer models. Now, dabigatran is a widely used anticoagulant. It's an inhibitor of thrombin. And Boanji's group in Mayo Clinic actually demonstrated this first in one of their models, that it shows efficacy against pancreatitis. And they've been speculating that maybe anticoagulation improves pancreatitis. But we looked at this compound and we said that this should inhibit trypsin also. In fact, there was some data in the literature it inhibited trypsin. So what we did, we tested it against a panel of trypsin isoforms, and it turns out dabigatran is really a potent trypsin inhibitor. And we felt that it's a great test case to see whether it would improve pancreatitis. Now, dabigatran is given as a prodrug called dabigatran etexylate, and it gets converted, it gets absorbed as a prodrug and is converted in the blood to dabigatran. So we ran a test experiment and we looking at absorption and levels of dabigatran in mice. And this is after oral administration of dabigatran etexylate. And you can see there's a rapid increase in blood levels, and then there's a decline within 4 hours. So it needs actually repeated dosing in if you want to maintain, high dabigatran levels. Importantly, what we looked at is how effective it's against trypsin, and you can actually measure the inhibitory constant, and which is between 10 and 80 nanomolar, and then you compare it to plasma levels, and you can see that blood levels way exceed the required inhibitory levels for trypsin inhibition. So this seemed to be a good compound. The caveat here is that we cannot measure pancreas levels of the inhibitor, so we're measuring blood levels. So we're hoping that in the pancreas it can reach a similar concentration. So we use this model where trypsin activation is low and you induce pancreatitis. And the readout is the pancreatic atrophy, S-inertial atrophy at 5 days. And if you look at the histology, if you just no treatment control, looks very nice. If you induce cerulean, induce pancreatitis by cerulean, you see that the typical S-inertial atrophy. If you give them a single dose of dabigatran right after induction, you completely prevent disease, and everything looks normal. So this was very encouraging. So we looked at a large number of mice to see, the variability of the treatment. And on the left side, again, you see pancreas weight, very easy measure. So no treatment control. Then you see the atrophy, pancreas weight drops. You treat them with dabigatran, pancreas weight normalizes in a large number of mice. Or you can do the histology scoring, and then what you see is that about half the mice show a complete response to dabigatran, and then the 2 mice had no response, and then a bunch of mice had partial response. So overall, we consider this extremely encouraging, that trypsin inhibition might work in these models, and they might restore normal pancreas histology. The partial response is very interesting mechanistically. We don't have a complete understanding of that, but we are studying it. So to summarize this, what I was discussing in this sort of scheme, using trypsin-dependent pathway and PRSS1 mutations as an example. So in human genetic studies, we identify these mutations. Then in functional studies, we learned that the mutations either stop degradation of trypsinogen or directly increase activation of trypsinogen. And then based on this, we modeled it in mice, and you have 2 phenotypes. You have acute pancreatitis and progressing spontaneous with a chronic pancreatitis. And then we tried to use these new models, now testing different compounds. And I showed you one recent example with dabigatran. So we hope to proceed with preclinical testing in the coming years, because there's a sort of renewed interest in trypsin inhibitors. And this is due to the pandemic. I'm sure many of you know that the viral entry is dependent on the trypsin-like protease. And because of that, there's a lot of trypsin inhibitors have been tested, clinically. So we have now a lot of clinical data on trypsin inhibitors, which are ineffective in COVID, but I think we can repurpose them now for, testing in trypsin-dependent pancreatitis. So with this hopeful message, I thank you for your attention, and then look forward to this discussion. Oh, and the people responsible for this is 2018, the before pandemic Boston dinner, and then moved to UCLA, and then this is how we spent our first years after the move. But luckily the lab remained open, which was a big help. Thank you.
Excellent. We have time for a couple questions for Miklos. There's some microphones going around, so please.
Hello. Is this thing on? Yes. I just had 2 quick questions about your methodology. The first one being, did you use both male and female mice throughout the entire study? or is it only male?
Yes, yes, we always use both males. And actually, I don't understand this fascination that people always use male mice, because female mice is actually easier, because female mice stop gaining weight. And so you can keep them a long time and they still weigh the same. So it's much easier to design experiments with female mice. But a lot of people just always go for male mice. We mix them. It's a 50-50 mix.
Okay, great. And then the second question that I had was for the cerulean model that you did, was it 1 injection or 2 injections? And was it the typical high dose of 50 mg per kg, or is it something else?
Yeah, I didn't specify it. It was in this particular experiment, it was high dose 8 injections. But it turns out with the different trypsin models, you can vary the number of injections. Some of them respond even to a single injection and they develop pancreatitis. And if you give more, then you get more severe.
Okay, great. Thanks.
So this needs to be standardized a little bit across models.
All right. Thank you.
Miklos, this is great. So I have questions about like using mouse models in general for chronic pancreatitis. So can you comment about islet function in general in mouse models of chronic pancreatitis? I think in general they don't get hyperglycemia or islet dysfunction. And what was it in your model? And then can you also comment that they get fatty degeneration and not so much fibrosis, and how can we model mouse chronic pancreatitis going forward for clinical studies if there are some discrepancies between humans and mouse?
Excellent question. I get that all the time. And so we haven't studied islets. If you look at these mouse models, the islets look great. And some people look at, and they say they also function great. They may even be bigger. So mice do not seem to model humans in terms of diabetes, and then that's where the ferret models come in, hopefully. But we haven't been, that interested in the endocrine part, unfortunately. So the second part is the fatty replacement. I think that's fascinating, and we don't fully understand it. Why you cannot drive end-stage disease to fibrosis in mice? I don't really know. If those of you who done pancreatic cancer KRAS mouse models know that you see massive fibrosis in those models. It's just really amazing. Complete acinar cell atrophy and just fibrosis everywhere. So the pancreas is capable of developing fibrosis, but not for the chronic pancreatitis. And even I'm referring back to acetic acid, which is a very non-specific treatment. Even there, you don't see any fibrosis. You see fatty replacement of the pancreas. So looks like that the intrinsic response of the mouse pancreas is to repair is just fat. And I think that's fascinating because we can figure out something that what the role of fibrosis might be, like in diabetes, for instance.
Well, thank you, Miklos.
Thank you.
Just have to keep on.
Good morning, everyone. We're moving along